the INRIA triumphant, or perhaps even musketeers. Personalised electromechanical model of the heart, prediction of acute effects of cardiac resynchronisation therapy. Maxime Sermesant.
I'd like to join the thanks to the organizer because I could hardly think of a cardiac modeling expert not present here, so I learned a lot from all the experts and it's really a great meeting. So also after the talks of Reza and Nicola, you probably have seen most of my slides. And from a discussion with Nick, he said that the first time you say something, people tend to believe you, but if you repeat it too much, then people get doubtful. So I hope I won't reach this threshold. Anyway, I'll go probably quite fast so we have time for discussion. So it's a joint work between King's College and INRIA on this CRT. So you've seen this approach of trying to personalize models to patient data for diagnosis and therapy planning. And yeah, Reza illustrated very in detail the different problems of CRT and what could be done to improve it. So this work is mainly focusing on the acute effect on where is the good place to put the pacing lead when you want to implant a CRT device, and how could you optimize the settings of this device in order to get a better outcome. So these are the different levels of modeling that we are interested in, that were also described this morning, from the anatomy to the electrophysiology to the kinematics and then to the mechanics. And as we build up, each stage is using the personalization of the previous step. So the idea is if we have data from a patient in sinus rhythm, and if we adjust all the parameters to this sinus rhythm, are we then able to predict another pacing condition for this patient and see what is the output of the heart of this patient if we excite it differently? So you know everything now about this XMR system and about the ability to register the MR data to the data acquired under fluoroscopy, so all the electrophysiology data. And so from this data, which is 3D plus time data, so a beating heart which only stops beating when you put the video into PowerPoint, but you can also get some information about the scars and the anatomy of this patient. And by fusing everything together, you can have in the same coordinates the electrophysiology information on the endocardium, the scars location, and the anatomy and motion of the muscle. So once we have this kind of fused data, so the first step is to create this personalized mesh that we already heard about. So there's been literature on segmenting the myocardium in clinical data for decades, but there's still no tool that is really automatic and working when you input some clinical image. So we still rely on some interactive segmentation where you put points in 3D and you build up a surface, and then using this surface, you generate meshes as Hervé presented, and you subdivide this mesh following the American Heart Association segments, for instance, and the different ventricles, and you input the labels to the scar regions. So once you have this mesh, as we heard, you need to have these fiber orientations, and we cannot measure them in vivo yet, so we input this statistical knowledge on the fiber orientation to get some fiber orientation in each tetrahedron of the mesh we use. So this is the statistical atlas, the mean fiber deformed into the patient geometry. So of course, as it is a patient, there is a pathology, and there are areas around the pathology, like around the scars, where the fibers are different and the anisotropy is different. But as we don't have yet any measurement in this, for the moment we still use normal directions. But of course we hope that by measuring some in vivo data on diffusion, we would be able to adjust around the pathological location this kind of information. So then the idea is to go to the electrophysiology. So from the different kinds of models that are developed, we think that for the CRT patients, which is really a problem of synchronization in the contraction, using an iconal model which directly models this activation time could be enough in order to reproduce the data and predict some interesting indices. So we chose to use the iconal diffusion model proposed by Colif Hansen, where here the variable is directly the activation time of a given point of our mesh. And we have parameters related to the local conductivity of the material, of the tissue. So in order to solve this equation, there is the fast marching method, which is very well known to solve the classical iconal equation, which is here. But it fails in case of high anisotropy. So under conical glue, propose an algorithm to simulate the anisotropic version of this equation with the fast marching method. And also, compared to this method, to this equation, we have a curvature term because the curvature of the front influences the local speed of propagation. So we have to do an iterative scheme in order to solve for the curvature effect. And we implemented this on tetrahedral meshes. But also, this iconal model only solves for the dynamics of the depolarization front. So we coupled it with some kind of discrete cell behavior in order to have different states and be able to have points which go back to resting behavior and which can be excited again. So then how do we adjust this to the data? So this is mainly the work of Fanish Chapatnam, who is in the room. So the idea is that we only have data on the endocardial surface, but we would like to adjust the parameter of the whole myocardium and get the activation time of the whole myocardium. So we first designed a method to adjust on the endocardium and see what we could predict, and we already saw some results. But here we try to combine the criterion with another criterion, which is the duration of the QRS, which more or less gives us an idea if the conductivity in the myocardium that we don't see is more or less in the right range. So by adding this kind of criterion, we could steal from endocardial data. So this is the mapping of the activation time of the patient. So it's got a left bundle branch block, which means that there is no excitation of the left his bundle. So the excitation only comes from the right ventricle, and you can see here the onset of the excitation in the on the left endocardium, and then propagates. So by using the criterion I just showed, so we minimize both the difference of the volumetric model on the endocardium surface and in the total QRS duration. We can get this kind of isochrones. So we have more or less to guess on the right ventricular septum where the onset started from where we see it on the left ventricle. And we space here and adjust the conductivity in the myocardium in order to have a good agreement between the isochrones measured and the simulated one. So here's the error, and to give you an idea, the light blue is around 20 milliseconds. I mean, there are still some error, but the data is also quite noisy, so we think it's already a pretty good agreement. And here are the kind of maps we can get. So in this adjustment, we have a layer of tetrahedra, which is on the endocardium, which we think more or less represents a Purkinje network. So you could see on this layer that we get very high values, which probably represent parts of the Purkinje network, which is still working and which is activated by the right ventricle activation. But we get also a conductivity in the other part of the myocardium in order to still be correct with respect to the QRS duration. So once we have this activation time for all the points of the mesh, we can input that into a mechanical model. So yeah, we use this standard approach of simulating the mechanics with a contraction which is controlled by this depolarization. And as showed this morning, to adjust first the kinematics, we add external forces derived from the image in order to have a motion which corresponds to the image. So this is more or less the state estimation of our electromechanical model. But once we have this, we want also to change the mechanical parameter to really go to the pressure and the mechanics developed in the ventricle. So for this, we go to a more complex model, and we change for the moment manually. So this is the work of Radomir Chabignoc, Dominique Chapelle, and Philippe Moirot at INRIA Rocancourt. They currently only manually, but they modify the parameters of this model in order to match the motion and they get in their simulation and the motion extracted from the images, and also to match the pressure curve that is measured during the intervention. So as you saw, we get then a reasonable agreement between the pressure in the ventricle simulated and the pressure measured in the ventricle, and also this index of dPdt and dPdt max, so the derivatives of this pressure. So then the question was, after all this work, can we at least predict something for another pacing condition? So if we pace this patient very differently, so here were the baseline isochrones coming from the right ventricle, and in this case he's paced from the coronary sinus but also there's a catheter pacing on the endocardium and another catheter pacing in the right ventricle. If we extrapolate and readjust the activation times from this kind of data, so here are the activation times we get, can we predict the pressure output of this heart? So you can see here so the initial conditions were different for the model and the final isochrons compared to the data. And we could see that it allowed to recover the difference in DPDT max that was measured between the baseline sinus rhythm and the pacing mode. And as you saw, we did this for different pacing modes for this patient and compared each time the measurements and the simulation in this DPDT max index. So, of course, there's still a lot of work here. First of all, validate on more patients and more pacing conditions. As I said, the image processing part, we would really like to get it more automatic, but still very challenging. Reza already mentioned the in vivo DTI that we hope to get. It won't be 3D, but even a few slices in the right locations could be already a big advance. For the electrophysiology model, it can be the case that we won't be able to represent all we need with the iconal model. So if it happens, then we will see how to integrate additional blocks like the stretch, the difference in connectivity created by stretching. Also, we want to validate the motion we predict, but we cannot put back the patient into the MR scanner with all these catheters and all these metallic parts in his body. So we'll have to rely on real-time 3D echocardiography to get motion when it's paced and to compare with the prediction of motion. And also the automatic adjustment of mechanical parameter is a great goal, but due to the changes of phases, which are quite abrupt changes in boundary conditions in the heart cycle, it's quite difficult to have an automatic loop which takes everything into account. And finally, the problem of the outcome for patients comes really much later than just the acute effects, and we should be able to predict the remodeling of the heart to really know what will be the outcome for the patient if he really feel better or not. So this is also a quite long-term goal, which is very challenging, but probably very interesting for this therapy, and try to optimize also the setting. And yeah, just to finish this citation, which I really like from Garni, Noble, and Cole on dimensionality in cardiac modeling, which restates that you should really select the model depending on the application you want to do, and try to find a good level of complexity depending on the level of data you have and the level of information you want to get from your model. Finally, some advertisement for this workshop, mixing also imaging and modeling at MICAI, organized with Nick, Carol, Reza, and thank you for your attention.
Great stuff, Pat. I just got a question about your use of the image forces, because it seems to me if you're using image forces, I know why you do it to help improve the actual kinematics, and it does a really good job of doing that, but if you're also trying to then predict the lumen pressure, will not the image force actually affect that estimation of the pressure? I mean, how do you account for that?
Yeah, that's why, in fact, it's just for the estimation of the motion. And then when we go to the pressure, we change the parameter to try to match this motion, but we don't use image forces anymore. Ideally, these image forces would be the error criterion for the automatic adjustment of the mechanical parameters. But yeah, for the pressure, we don't have any image forces anymore. Otherwise, yeah, clearly it would impact the...
So if you're using the image forces to match the motion and to estimate mechanical properties at the same time, or?
In fact, it will be, I mean, it could be a two-step. You could first estimate the motion, and then from this motion, try to do the automatic loop for adjust the mechanical parameters, or directly use it as an error criterion when you, yeah, this is still a good point.
Talia.
Excuse me for not being really up on everything that you're doing, but do you have constant delay between the electrical activation and the mechanical activation? Do they always follow? How are they linked in your model?
Yeah, there's more or less constant delay. I mean, we can change it, but it's...
Well, isn't that a problem? Because a patient which has a more than 120 milliseconds, let's say QRS complex, will always be associated with very long delay, and patient in the mechanical activation, because it follows the electrical, right? So, but there are patients who have a very short QRS complex and still have mechanical desynchrony. So how would your model capture that?
I mean, we could potentially put that as a parameter to,
How would you
to
know to
adjust.
predict that?
Because we've got data both on the activation and on the motion, so we should detect this delay from the mapping we have and the image data we have.
I see, so your input comes from the imaging into the electrophysiological model, electromechanical rather, for that
Yeah.
particular patient.
Yeah.
I see.
Last question for Andrew.
So, am I right in understanding that all the parameters that determine the pressure waveform were properties of the myocardium?
Yeah.
Because in
Yeah.
reality, the pressure waveform was largely determined by the properties of the circulation, right?
Yeah, I mean, yeah, the afterload and preload were adjusted also. Yeah, on the baseline measurements, we had more or less an estimation of the arterial pressure, and yeah, preload afterload are also adjusted in the model. Yeah, the boundary conditions. But then when we change the pacing condition, we don't change these anymore. But yeah, of course, yeah, the preload afterload are important for the adjustment. Yeah.
Right, I think we should move on. Thank Maxime again.